So need for an endotracheal tube. So there's 4 reasons why you need to put an endotracheal tube in. And there's 4 reasons why you mechanically ventilate the patient. There are 2 different things. So right now we're just going to talk about why does the patient need an artificial airway? Why can't they breathe on their own like we do? Okay, so you said need for suctioning. And this is all in your Airways PowerPoint. Does everybody have that with you today? Your Airways PowerPoint? Henry's got it pulled up?
I don't have it.
Do you have it?
I don't have it.
Okay. So I'll have it up so you just take notes.
They can
Turn
open
on
the
the computers?
and go into Blackboard.
Yeah.
Open
We
the
do have
laptop.
computers.
Go into Blackboard. Pull up the lecture. Okay? Boot that thing up and then you can follow along with John.
That takes a little bit to read on. Okay, what's another reason we might need to put an artificial airway in? So if somebody has a lot of secretions and they cannot cough them up, right? And they might need to be suctioned. If you had a patient who had a stroke and they're starting to gurgle in their secretions, they have a weak cough, they're not able to cough them up, what would you recommend as the respiratory therapist initially? What would you recommend? They're gurgling, and here's their cough. You're telling them cough, cough. They just can't. What would you do initially to help them move those secretions?
Initially,
Initially.
maybe move their head,
Move their head.
back so their neck.
Okay, so their head's back. They don't have the strength to cough those secretions up.
Suction.
What are you gonna do? Hyperoxidate, so you give them oxygen, and they're still gurgling in their chest. Okay, chest physical. So you do chest physical therapy. Good. So it's still there, but now here's their cough. They just don't have a strong cough. They can't get it out. So how are you going to get it out for them? You're going to suction them, right? How are we going to suction them when they don't have an artificial airway in? How do we suction them? The Yankauer, it's too far down. It's not in the back of their oropharynx, so you can't get it. How are you going to suction them? You learned about this last semester. Inline, you don't have an endotracheal tube in yet. So how are you going to get down into that trachea with the suction catheter? You said you're going to suction them. How are you going to get in there?
Through their nose,
Through the nose. What is that called?
nasal.
Nasal tracheal suctioning. Okay? So you're going to nasal tracheal suction. So we've done it. We're getting a lot of secretions up. They're thick. And the patient's sats are coming up because we're getting all those secretions out. But now, 30 minutes later, you have to do it again. Okay? And you cause some bleeding in that nair. What can we do to prevent more bleeding when we have to suction again? Huh? We're going to lubricate. What else can we do to prevent any mucosal injury to the nasopharynx? Thanks.
Don't pull back. Every time. Don't pull back. Every time it's.
I'm causing injury right as I go into the nair. So you've lubricated it. That's good. You lubricated it. What else can you do?
You can use a nasal
Thank you, right, guys? You gotta remember this. This is putting it together. You have to use a nasopharyngeal airway, okay? An NP airway. So you lube up the airway and you put it in the patient, so then you can frequently suction and it's not gonna scrape up the mucosa, okay? So we're gonna put an NP airway. So we're suctioning and suctioning, and they start deteriorating because we're not able to get enough secretions out, okay? Number one of the reasons that we need an artificial airway or an endotracheal tube is the need for suctioning a patient, keep their airways clean. So we say, well, we've tried and tried and tried, patient's deteriorating, we're gonna have to intubate just to keep what we call good pulmonary toilet. Have you heard me say that before? Pulmonary toilet is an English term that is used in the medical field. And it means to keep the airways clean. So the physician might even write as an order, pulmonary toilet for the patient. And that's what that means. Keep their airways clean, okay? So now we need an endotracheal tube because then we can get into the trachea, right, further down and suction out all these secretions out of our patient. Okay, what's another reason that we need to have an artificial airway?
Risk for aspiration.
Okay, give me an example.
Maybe they're choking on their own saliva. Maybe they have a lot of saliva in their mouth, or
Risk for aspiration. So somebody that might not really be responsive, right? Give me a scenario where somebody might not be responsive and you have to put an endotracheal tube in them in order to protect their airway so that they don't aspirate food into their lungs. Somebody that maybe had a brain bleed, so maybe they had a stroke, a CVA, cranial vascular accident, and they are unresponsive, and now they're at risk for aspirating what they had for lunch, okay? What's another example of somebody needing endotracheal tube for risk for aspiration? So somebody that had a stroke, what's another example? How about those teenagers that go to the party at night? And they're doing beer bongs. Anybody ever heard of a beer bong?
No.
No? They have a tube and it's a college thing.
Yeah, I know.
And they drink, right? And they just drink them down. 3 beers in a row. Keep doing that and you're gonna be obtunded. The alcohol level is gonna obtund you. You're not gonna be responsive. And when you are not responsive, that big dinner you just had, it's in your stomach, now you can aspirate it and you're not gonna have a gag reflex to protect your airway, your sterile environment in the lower airway, okay? So risk for aspiration. So if somebody comes in and they're not, if they were in a car accident, let's say we're in the trauma room, and they are unresponsive, anybody who cannot protect their airway is at risk for aspiration. So anybody who's unresponsive, if they had a seizure and they're unresponsive, they're going to be intubated, okay? Because they cannot protect their airway. What is another reason that we need to place an artificial airway into a patient's oropharynx? So if we have an airway obstruction, give me an example. Looks better already, Nina.
Try it. Before I have to get on the computer.
So if you have an upper airway obstruction, put this in here, upper airway obstruction. What we call an upper airway?
got me at 3V60s. How beautiful is that?
You got what?
3V60s.
That's great. I'll give you one that you haven't learned yet. Epiglottitis. Epiglottitis. Something that children can get. It's a virus that bacteria that kids can get, and it can cause upper airway obstruction, and they need to be intubated. Okay? What's something else that would obstruct an upper airway that you might need to be intubated because you can't bring air in for gas exchange? If you get a mucus plug. Okay. So if you had a major mucus plug, they might need to intubate you so that they can do a bronchoscopy. So a major mucus plug. How about a tumor that's growing? Lung CA. So a tumor that's obstructing the airway. You need an endotracheal tube. Okay, so what's the last one? So these are the reasons why, these are just for a tube. Why do we need an endotracheal tube? There's 4 separate ones for why do we need mechanical ventilation, which you'll learn about. So what's the 4th one for a tube? Yes, if you need mechanical ventilation. Okay, so if you're not able to create enough gas exchange, okay, to maintain arterial blood gases, then you're going to need mechanical ventilation. We're going to have to support your breathing. Okay, and usually these patients who need mechanical ventilation, they have ventilatory hypoxia. Usually these patients aren't able to blow off enough CO2, and they develop a respiratory acidosis. So we need to ventilate them because they're not able to do that for themselves, okay? So those are the reasons that we need artificial airway. Okay, so I'm going to give you each. This one is for you. This one is for you. We're going to look at our endotracheal tubes. This one is for you. I like the shield. Does everybody have an extra face shield at home that you can wear for clinical on your first day? Okay. And an N95? I do not want you wearing whatever you have in clinical to the lab. So keep them separate.
Oh, yeah.
So like your masks here, we're going to keep them in your bags. We're going to throw away your old stuff and put your new mask in your bag. Okay? So make sure you have an N95 at home and a face shield to wear on your first day. Okay? All right, so here's...
They're giving them N95s, right?
We can give them
No,
a,
the clinical
not
side.
for the first day. I want them to have one for their first day going in.
But they don't have one.
We're gonna give them one.
Oh, we're giving another one?
Yeah.
Oh.
There you go. Does everybody have a syringe? Yeah, you guys have syringes. There's a syringe. Here. But we don't need 2 syringes. Okay, so everybody look this way. Did everybody bring water for today? Bottled water?
Yeah, I've been good.
Yeah.
Oh, it's second years.
Guys, I'm coming. I'm in the left. I'm in the
Okay.
left one.
She's got it.
I'm coming, I'm
Second
in the
years
left.
have their
You're-
clinical day. Their
you're
clinical days are
okay.
Tuesdays and Thursdays.
Okay.
Okay, so let's just pretend like we are going, we are called to the ED, the emergency department, and we're called to intubate a patient, okay? Now, some hospitals, the smaller the hospital, the more likely a respiratory therapist would be intubated. Yeah.
Sorry, I'm just trying to give 5 in a row, that's what's going on.
You're trying to do what?
There's
Oh,
supposed to be
5?
5 in a row, that's why we don't have room. I'm just gonna pull that other B60 and then I'm gonna do it.
No, it looks better already. Okay, good. Let me just say hi to them.
I'm so sorry. Oh.
Hey guys, we have first years here. You wanna say hi? Second years are on
I
the line.
remember that guy. Yeah.
Yeah, I'm coming, I'm just
I'll see you
finishing up.
guys Thursday morning to talk about your clinical rotation, okay? Okay, all right. So we're going to the, okay, so some small hospitals, they will have respiratory therapists intubate. The smaller the hospital, the larger the hospital, less likely. Because you have residents, medical students, PAs. You have a lot of people that want to learn how to intubate, so less likely. But smaller hospitals, especially if you work night shift, more likely that you will be intubating the patient, okay? I have never had to intubate. I've done a cadaver,
Sorry.
but I've never had to do it because I work at a medium-sized hospital, Prince George's Hospital. So they always have surgical residents, medical residents. We had so many residents that I never had to do it, okay? I have done a neonate, so that was pretty cool, but I did it with the doctor. Okay, so we are going to the bedside in the ED, and let me grab it. Everybody grab your endotracheal tube. Okay, everybody has an endotracheal tube? So, my biggest thing is that you have to prepare, always prepare for an emergency. So when it happens, you're ready, okay? So if you think somebody's gonna be getting intubated, there's a code card, a crash card, an airway card, every area in the hospital. Make sure you know where that card is so you know where your equipment is. If you think your patient's gonna be intubated, gather your equipment early, before it happens, so that you're ready. Okay, so if everybody picks up their ET tube, tell me what you see. What do you see on your ET tube? What markings do you see? Huh?
The tube size.
Okay, so where does tube size, where does it say the tube size? So for an adult, we usually do eights across the board for adults. If you're orally intubating, we do 8s across the board. Rarely have I seen a 9, okay? And you need at least an 8 size ET tube if you're gonna bronch a patient, you need an 8. Okay, if you have a very small little old lady who they can't get an 8 in, they might use a 7.5. But mostly adults are an 8. If they're nasally intubating, could be a 7, probably a 7 for nasally intubating. Okay, does everybody see where the what size do you have? You have a 7.0. So she has a size 7. So let's look at the difference. You hold up yours, hold up your 7. See the difference in the area size? Okay, the orifice is much more narrow. So if you think about constantly breathing through the straw, the smaller the straw, what happens to airway resistance? It's going to increase, okay? Even having this tube in increases airway resistance. All right, we'll talk about that when we get into lectures. What size do you have? 7.5. So hers, show them. Hers is at the top. It's up here. Mine is 8.0. Mine is right here. And it's in millimeters. Does everybody see their tube size? Okay, so now we know our tube size, because when you're getting your ET tube ready to intubate, you're gonna have different sizes. So you gotta pick the size you think that best fits. Usually, as I said, it's an 8. So we got our 8 ET tube. What size do you guys have?
I got an 8.
You both have 8s. Okay, what else do you see here? How about the length of the tube? Henry, what are you seeing for length of tube? Where does it say?
Okay, sure.
Is it the one behind OD?
So see all your numbers? 20,
Oh, yeah.
22, they're centimeters. So
Yeah,
the
30
size of the tube, the 8 is in millimeters. This is in centimeters, the length of the tube. And it goes up to 30 centimeters, okay? So most tubes are 30 centimeters long. And we usually tape, so once you intubate your patient, right, you have it at a marking point. So we usually tape at the lip when we're securing this ET tube, okay, either a harness or tape. We're gonna tape between, I think it's 20, what is it, 21 and 25? I'll have to look, because they've changed it. We always taped 22 to 24 for a female and 24 to 26 for a male. They've changed it. So now it's a certain size for the lip, and it's a certain size if you're taping at the teeth. Okay? So it's like 19 to 22, whatever it is. We'll look at the thing. So you have to see where you're securing it, and you're going to mark that. Wherever you tape it or wherever you put your harness, that's where it needs to sit. Okay? Because this ET tube needs to sit how far above the carina?
3 or 2 or 3.
3 to 6 centimeters above the carina. So if you tape it at 24 at the lip, and you are at 3 centimeters above the carina, then that's a good tube position. And you're gonna see that on x-ray. So we need to mark it. ET tube at lip, 24 centimeters. ET tube at teeth, 19 centimeters, okay? Now I'm gonna say this. Whatever institution you work at, wherever they do it at the lip or the teeth, you have to be consistent with wherever you're working, okay? Because if an institution says, we're 24, it's at 24, that's how they'll talk. The therapist will say, well, it's taped to 24, all right? And if she's talking about lip and you're talking about teeth, no, it's taped at 19, there could be a discrepancy, all right? So you have to be consistent with whatever the institution says. Nina works at hospital center, she did. And they always talked about taping at the teeth because they're a burn center, right? So their lips would burn and swell up. So you'd have to measure it at a stable place, right? So they would do it at the teeth. At PG, we've never done it at the teeth. We've always done it at the lips. So just be consistent wherever you work, all right? So we have the size of the tube, we have the length of the tube, and there's a radio opaque line. Do you see this line on the ET tube? This radio opaque line is so that it can be seen on an x-ray, on a chest x-ray. So you can see how far down, it goes all the way to the end. You can see how far down this tube is gonna sit on x-ray.
Is
Like
it
I said, it
bag?
should be 3 to 6 centimeters above the carina. It's a blue tube on the back of the,
This one.
you see it, Mateo?
Yeah.
that's the radiopaque tube. All lines and tubes have that radiopaque line so that you can see them on an x-ray. Okay, what else do we see? What is this? Huh? Do you know what it's called? It's a pilot balloon. Okay, it's a pilot balloon. And there's a valve inside. There's a spring valve. Okay, so this is how we blow up our cuff. This is how we inflate our cuff. Okay, everybody, if your balloon is inflated, we always use a 10 cc syringe. And I want you to pull the air out of your cuff until it's deflated all the way. You're going to pull the air out. So now mine's deflated. See that? So you must have it deflated before you're going to put it into somebody's airway, right? Okay. So this is the cuff. This is the pilot balloon and valve. All right? When we're getting it ready to intubate, we need to check our cuff to make sure there's not a leak in it. Okay? So we're going to inflate it with a 10 cc syringe. So preset your syringe to 10 cc's. Yorda, preset your syringe to 10 cc's and you're going to inflate it.
I got 5.
You have a 5, well that's the thing, you just have to do it. Do I have a 10 over here? I do. So we always get a 10 cc syringe because it's easier to work with. Okay, and we're going to inflate our balloon. And you have to do it again. We need to put more air into it. We're going to inflate this balloon. See how it's inflated here? Yeah? I want you to feel the pilot balloon when you have it inflated good. Because you're going to get used to how this feels, whether it's inflated enough or not. Okay? So this is holding air. I can add more air to it. This is holding air so I don't have a leak. So my tube is good to use. Okay? If you filled it up too much, it would pop. This one is leaking a little bit. See how it's deflating a little bit? It's old. We use them a lot. Okay? So, those are what we have for our tube. There's a hole at the end. Okay? Can anybody tell me what that hole's for? What is that hole for? So this is how you're breathing through, right? Patients got it in like this, and they're breathing through this tube. So why do we need a tube on the side? It's called a Murphy's eye. It's called a Murphy's eye, the tube on the side. Why do you think we need that? Why is there an extra tube? An extra orifice. Orifice is opening. Why is there an extra orifice on the side?
In case it becomes oculated on the other side?
In case it becomes obstructed? Yeah, so in case you have like a thick mucus plug that blocks here, you still have access to get air through, okay? So the Murphy's eye is an extra orifice in case your main port becomes obstructed, all right? So now we have checked our cuff, and we have a good cuff. So what I do is I usually preset my syringe, okay? And I'm gonna keep it just like that. So when I intubate, I can just inflate with air, okay? But now I need it more rigid to intubate a patient. This is kind of pliable and floppy, okay? When you're intubating and you're looking for your the epiglottis, you're trying to lift the epiglottis so that you can see what structure are you looking for when you lift the epiglottis?
Cartilage?
what's that orifice called? That opening into the trachea, what's it called? What is it? Vallecula is in the back base of the tongue. So we can lift through the vallecula or directly, which we'll talk about that. So when you lift the epiglottis, so that's a flap. You've got a tube, right? You have a tube, and this is the epiglottis is a flap. What is the name of this opening, this tube?
Is it the glottis?
It's the glottis, right? So when you open up that epiglottis, you should see the glottis, and inside the glottis is the cords, the vocal cords. So you're looking for the vocal cords, and that's what we're going through. That's the anatomical structure we're looking for, is the vocal cords. So, does anybody know what this is called? It's called a stylet. Stylet. Can you say that?
Stylet?
It's a stylet. So it's rigid. I want everybody to place their stylet into the endotracheal tube. Okay, you see the stylet does not go past the end
Yeah.
because we don't want it to rip or tear the lining, the endothelial lining. Okay, so we've got our stylet in there. Now it's more rigid. And we never touch this with our hands because this is going into the lower airway, which is a sterile environment, okay? So it's going to be in a bag, in a sleeve, right?
Yeah.
We have our gloves on, so we're never going to touch the bottom part of this. We're just going to be touching the upper part, okay? If we wanted to put this down so that we can get our other equipment ready, we're going to put it back in its sleeve. Never put it on the bed, which I see happen all the time. Okay, physician tries to intubate, he can't intubate, and he puts it down on the bed. Okay, full of secretions, just going into a sterile environment. Put it back in the sleeve. You're the therapist. If you're assisting, make sure it goes back in the sleeve. Okay, you're the one handing him the tube if you're not intubating, if you're assisting. All right, so you want to hand him the tube with everything ready. So if you're standing to the left of him, you're going to hand him the tube like this. If he's standing here and you're here, you're going to hand the tube like this, all right? So we have this rigid tube here because we have the stylet in here, and with the sleeve that's on, you could just kind of angle it a little anterior because lots of times that trachea is a little more anterior, okay? So we're going to bend it a little bit for the physician. Okay, so we have done that, and when we're going to intubate, okay, I want everybody to try this. This blade, we need a laryngoscope and a blade. It's not coming out. That one's not coming out. Okay, the straight blade, everybody, you have to know this. You're going to see this picture, you're going to have to tell me what it is, okay? This is a laryngoscope handle. This is a laryngoscope handle. It has batteries in there, C batteries, 2 C batteries. This is the blade. This is a straight blade, and there's a light there, okay? The light is so that when they place the laryngoscope in the patient to intubate, they can have light at the end so they can see what they're doing, okay? This curved blade is called a Macintosh. The straight blade is called a Miller. So write that down. Straight blade is Miller. Curved blade is Macintosh.
You said curved blade is what?
Curved blade is Macintosh. It's in your PowerPoint. Macintosh, and the straight blade is a Miller. Okay? The sizes we use for adults are 3 and 4. In your PowerPoint, it just says 3. But we use 3 and 4 in the critical care or on anybody that we're intubating for adults. And you can get a 3 or 4 size for a Macintosh, 3 or 4 size for a Miller. okay? So it depends lots of times on the physician's preference if they're intubating. So like one of our intensivists, he likes a 4 miller, and I know that. So I would go, if he was intubating, I would go get a 4 miller. If my other intensivist was intubating, I would go get a 3 Macintosh. So it depends on their comfort level, what they feel more comfortable intubating with. Okay? So when you go to set it up, there's a little lip there that you're gonna put in here, push, and then your light comes on. Okay, so it's in place. I'm gonna have each one of you do it. If the light doesn't come on, we have older blades where you could try to screw that light bulb in better. These are disposable blades, so you don't have to do that. But the metal blades, you can screw the light in. Like if you turn it on and the light does not come on, okay? Couple things to troubleshoot that is by twisting the light bulb, trying to reset this to make sure it's seated right, and also to try to replace the batteries in here, okay? So that's why when you go on your shift, you have to do a check of your code card to make sure your handle works, your lights are working, because you don't want the light not to work in an emergency. All right, that's not the time. So, as we're talking, I want each of you to try to push this in here and turn on the light. So push down and push back in.
Oh.
And yeah, you got it. So you try it. And these mannequins, I wish we could have you guys intubate these mannequins, but they're falling apart on us. So I'm not gonna have you guys do it, but I'll talk you through it how we do it. When you get into the babies, I have baby heads just for intubating. So you will practice intubating in your neonatal class. Were you able to do it? Good. See how it takes practice? Okay, so push it in further. Like push it in here like this. So, take it, push. You gotta push before it clicks. So you're gonna push. Push, yeah, forward first. Push that way. There you go, you just clicked it. Your light's on? Okay, so take it off and then put it back on. So you would not want to be fumbling, right? When the anesthesia's there and the intensive's there, you're fumbling trying to turn on equipment. You don't want that to happen. So you always want to prep. Did you get it seated? Push it, push. Pull it, pull it. You did it, good. Okay. So what is the straight blade called?
Miller.
What is the curved blade called?
Muscle close.
What's it called? What's the curve?
Miller. Muscle close.
Macintosh, good. In your PowerPoint, if they ask what size we're going to be using, what size you're going to say? A 3. A 3. Okay? So, if we're going to be intubating this guy, we're going to pretend like we're going to intubate. Okay? Can everybody see me? If you can't, you might want to gather around. Just stay a distance because y'all don't have gowns on, but just so you can see. Everybody can see? Okay. So what's the first thing I want to do if I'm getting ready? What's the first thing I did? I checked my tube, right? Make sure my cuff's inflated. I want to make sure it's deflated all the way down before right? And you can lube it up. Okay, so it's back in its catheter. Not catheter, back in its packaging. Okay, so that's sterile. Now what do we want to do? And we never leave the lights on because they get hot. especially in the neonatal world, they'll burn the babies. Okay, so what's the next thing we want to do? We're getting ready to intubate this guy. So he's got a non-rebreather on right now. Okay? All right, so we've got everything. We want to get all of our equipment ready. All right? We have the stylet in here. We have the syringe here. We have an easy cap. Okay? So we're going to open up our easy cap to have it ready. What does the easy cap do? What does it do? What is it for? Yours have already been exposed. This is brand new. So when you get it out of a package, it's purple. Okay, it turns to yellow once it detects carbon dioxide. Okay, so we would put it on the patient to make sure that the patient's intubated in the trachea as opposed to the esophagus. All right? So that's what this is for. Okay, so we've got this ready. I've got my ambu bag. So what do I need to do with my ambu bag? I'm going to take his non-rebreather off. What do I need to do with this? Pardon me? Okay, so I need to connect it. So I'm going to connect it. How many liters?
10 to 15. 10.
For an ambu bag?
12?
Yeah, so I think it's 12 to 15. I would never do 10. I mean, you can go 15 or low flush if you need to. Does everybody know what a low flush is? No? So normally if I'm getting ready to intubate a patient or bag a patient, I'm turning it up to 15, okay? If I start to ventilate the patient and their SATs are not coming up, all right, then I can go to a low flush. I can go higher. Listen to this low flush. Hear that low flush? This is a high flush. Hear that? You don't need to be at a high flush, but you can be at a low flush. So you're going to start at 15. Okay? If you came into the room and a nurse was bagging, don't just take over without looking at your connections. All right? Lots of times, somebody might hook it to here by accident. I've seen it many, many times. And that's your responsibility. You're covering the airway. So make sure you're hooked up to oxygen. Okay? So now we're bagging our patient. He's intubated, but we're bagging our patient, right? Nose to chin. We're bagging our patient. We're doing the C to E, right? Position. We're bagging our patient. We're getting their SATs up to about 100%. We're hyper-oxygenating this patient, okay? So then we're gonna have, the therapist is gonna continue doing that, or a nurse. Then we're gonna get our blade ready, our handle on our blade, and this is what is this one? Macintosh. So we got our Macintosh ready. We have our tube ready. So whoever's assisting you is gonna be holding the tube, okay? So when you put the blade into the back of the throat, all right, depending on this type of blade, if you have a Macintosh, it fits into the vallecula. Do you know where the vallecula is?
The end of the tongue.
It's the base of the tongue. So the Macintosh fits into the vallecula. This will be on your quiz. Macintosh fits into the vallecula and indirectly lifts the epiglottis. Because you're not lifting it, you're lifting the vallecula, which is the base of the tongue, and that lifts the epiglottis. So the Macintosh fits into the base of the tongue, which is the vallecula, and it lifts so that now the epiglottis is lifted and I can see my cords, okay? The Miller is gonna fit underneath the epiglottis, so it's gonna lift it directly. Okay, so this one lifts it directly. All right, the Macintosh lifts it indirectly because it sits in the vallecula, lifting the epiglottis indirectly. This one lifts the epiglottis directly. Okay. so now I've got this, I've got suction, got my suction ready. And what should my suction be set at? What's my suction set at? What's suction pressure? What's normal suction pressure? And you want it on regular, not intermittent.
120?
120?
Yeah.
What's the range?
150?
What is it?
150, right?
120 to 150. So I'm at 140. Am I good? You want to check your suction. So this is all the stuff you're getting ready, right? Checking your suction. I have good suction. So I've got this ready. Okay, I've got my tube ready. Okay, we're going to try to intubate. When we intubate, we're going to put the blade into the right side of the mouth and sweep the tongue to the left. You sweep the tongue to the left and lift up. These take a lot of strength, okay, because they're flat, they're, you know, this material. You've got to lift up, so it's like up, because you don't want to rock backwards, you'll break their upper teeth, okay? So, lifting up, I'm suctioning out the airway, and you can do that for the physician, suction out the airway, and as they lift up, they're looking through here, and you can say, they'll see the cords. They'll say, okay, tube, you place the tube to the right and go right through the cords because you're seeing the cords. Okay? Once you have done that, we're going to place the CO2 detector on, okay, just like this. And I'm going to give a breath. Okay, so it's purple and then it goes to yellow once it measures CO2. Okay, I don't have any CO2, but once it's open to air, it's just going to turn yellow. Okay, so I give a breath and I have a positive color change because it turned from purple to yellow. So that means it's in the trachea, okay? So, the quickest way to determine if you've intubated in the trachea is to see chest rise. I will ask you that. What is the quickest way to see the endotracheal tube is in the correct placement? Because you're looking, observing for chest rise. Okay? The best way and most efficient is to get a chest x-ray. But the quickest way is to see the chest rise. Okay, so you've intubated. Now, what am I going to do once I intubate? What would I do next to make sure that it is? I've done my easy cap, and I have a positive color change. Means I have positive CO2 gases exhaling. So we're in the trachea. Okay, I've looked at my chest, it's rising. What would I do next? What would I do next? Anybody have a stethoscope? Do you want to listen to breath sounds? You want to auscultate, right? This is all on you. Okay, everybody's depending on you. So you're bagging and you grab your stethoscope and you listen in 3 places, okay? You're not doing the full assessment, 6 places. You're listening in 3 places. Tell me the 3 places that I would listen to make sure that that tube is in the trachea, not the esophagus. Tell me 3 places. Huh? Okay, so you want me to listen to the right lung, to the left lung, okay, to make sure it's not in the right main stem, right? So I'm going to listen to the right lung, the left lung, and then where else? Where would I listen to if it could be in the esophagus? The belly, right? You want to listen to the belly, okay? 3 places once you intubate, all right? No gastric breath sounds, but I hear breath sounds in the right lung and left lung. We have clear bilateral equal breath sounds. That's what you're gonna say, okay? So we've intubated, we've got bilateral breath sounds. We are good. So, some of this in the PowerPoint, I'm just gonna go through quickly because we've talked about. But if you were going to nasally intubate someone, let's say they had jaw fracture, you weren't able to orally intubate them, and you were gonna nasally intubate them, it would be a smaller tube like a 7, okay? And you're gonna lube it up really, really good. Okay, you're gonna put it down into their nares, so you would go in and down into their nares. And you can still use this laryngoscope so that you can lift up the base of the tongue and you can see the tube down there. These are what you call McGill forceps. These are McGill forceps, okay? So this is to assist you. So I see the tube at the back of the throat. Okay, this is going to assist you with pushing the tube through the cords. That's what McGill forceps do. Okay, through the cords, and we're nasally intubated. Questions? Pretty interesting, right? Yes.
So we are using
The McGill forceps for nasal intubation. Yeah, for nasal intubation. So what time is it? Is it 10? No, it's not.
9.
9? All right, so this is our beginning that we talked about. Okay, so just what I want you to underline or make note of on your PowerPoint is the tube should be approximately 21 to 25 teeth at the lip and 19 to 23 at the teeth, okay? 21 to 25 at the lip, 19 to 23 at the teeth. And nasally, it's 26. 26 to 28 at the nares. Okay. We don't do nasal intubation that often. But when we do it, it's there's some advantages to nasal intubation, some disadvantages. What do you think an advantage would be for being intubated? You think having something in the back of your throat into your airway would be less comfortable or more comfortable than going through the nose and going down into the airway? Which one's more comfortable, nasally or orally intubated for the patient? Huh? Nasally, because you've got that gag reflex going to the back of your throat, and that would be very uncomfortable, okay? So comfort, it's more comfortable to nasally intubate. But what would be a downfall for nasal intubation? We have a lot of drainage from our sinuses, right? So if you're blocking the nasal cavity, you're not going to be able to drain. You can get a lot of sinus infections. So we don't do that very often anymore, okay? But we used to. All right, there's all your parts to the tube. Bevel tipped. Oops, let me see something. I didn't show that it's bevel tipped right here so that it doesn't scratch the air, you know, the tissue. Adult 7.5 for female to 8 and male 8 to 8.5. Basically, we use 8s on everybody unless it's a really large male or a really, really small female. Okay. This is all the equipment we talked about. So we used to use tape to tape our ET tubes, and we would use cloth tape. But then they came out with tube holders. All right, let me see if I can grab your tube holder. And those work really, really well. So it comes in a container like this, and you have, it says do not remove because we don't like to remove it. But you would take this off, and then you have sticky tape here, this sticky portion here, and you would place it on the face, and make sure it adheres here. And then this is where you're gonna place it around the ET tube, okay, which is really nice. Because if I needed to move this tube from side to side, which we do, because it can break down the tissue on the lip, okay, I don't have to untape this whole thing and move it, which we used to have to do. Now, you just pinch this and you just move it to the side. See that? So it is very nice. You know how when new things come out, you know, it's hard to change. A lot of people didn't like them at first, but now people like them. The light wand is something that's new. That it's just a stylet that has a light on the end. It's called a light wand, and it lights up as you're intubating, so you can see it if you're in the trachea. You can see a glow. Okay. If you're in the esophagus, you won't see a glow. There's a laryngoscope handle. There's the Macintosh and the Miller. So remember I said about the Macintosh? Fits into the vallecula, the base of the tongue, and indirectly raises the epiglottis. This one fits directly under the epiglottis, so it lifts directly, or fits in the epiglottis, so you're lifting it directly. Okay? The Miller is what we use for neonates when we're intubating the babies. We always use straight blades. Okay, what position do you think we're going to put the patient when we're intubating? What's that position called we always talk about? Slightly hyperextending the head. Begins with an S. Sniffing. So remember that. You need to know that. It's called the sniffing position. You're going to place your patient in when you're intubating. And what does that do? When you slightly hyperextend, you're opening that airway. Okay, so that it's easier to see the cords. All right, that's some troubleshooting, which I already talked about. We have a glide scope, which is really, really cool. So this device here is new over the last few years, and it's lit up and it's connected to this video. So there's a video camera at the tip. So you can see exactly where you are because of this camera, and you can look at the screen when you're intubating. How cool is that, right?
Hmm.
So they have these in the ICUs. They have them pretty much everywhere now. So you can just watch the screen, and you can put the tube right through those cords. So if you put that tube right through those cords, you know you're in the trachea. You still have to do the other things, the easy cap, look for chest rise, breath sounds, but you know you're in the trachea because you saw it go through the cords. So that's called a glide scope. Has anybody seen any of these videos that are online? I know it's new, so this is what I would tell you. I put a few of them in here just because sometimes it's hard to do it at home. But all these videos that we have under each module is really an added explanation to what you just learned. So they're really helpful. All right, so let's see. I added this one here.
Hi, I'm Joe Escherick, and I'm the co-founder of Hospital Procedures Consultants, which is committed to delivering the best hospitalist and emergency procedures course available. My partner Rick Rutherford and I have over 10 years of national teaching experience and have trained over 1,000 clinicians just like you how to perform hospital procedures. Video about what? Blade, but there are very distinct differences from the standard laryngoscope blade. First of all, there is anti-fogging technology that helps visualization when there's trauma, bleeding, excessive secretions, compared with direct laryngoscopy. The second distinct feature is that compared with a standard Macintosh 3 blade, the GlideScope blade has a 60-degree angulation compared to a 20-degree angulation in the standard Macintosh blade. This improves the ability to access a very anterior larynx. The third feature is that there is a camera near the tip of the blade, which improves visualization of the larynx and allows for real-time video laryngoscopy. We're now pre-oxygenating the patient with 100% oxygen. Now we're placing the GlideScope stylet into the endotracheal tube. This is a special stylet that has a more angulated curve. Now we're applying the GlideScope blade in the midline of the mouth, following the curve of the tongue. As we introduce the blade, we're following the tongue down to the base, and we are now starting to see the larynx. There's the epiglottis that's starting to come up, and we can see the vocal cords in the middle. And now the blade is relaxed, and now it's elevated again to again visualize the vocal cords. The endotracheal tube is now being introduced along the right side of the mouth. And as it is advanced, you can see the tip of the endotracheal tube that is approaching the vocal cords. Once it's at the tip of the vocal cords, your thumb can help pull back the stylet as the endotracheal tube is advanced in 1 centimeter increments until the endotracheal tube passes through the vocal cords, and you can see the thumb is being used to pull back the stylet as the endotracheal tube is advanced further. Then the stylet is fully removed, leaving the endotracheal tube in place. The GlideScope is removed, and now the cuff will be inflated for the endotracheal tube with approximately 5 to 7 milliliters of air until the cuff is fully inflated. The endotracheal tube is now connected to the ventilator, and the procedure is complete.
General anesthesia, they give you enough anesthesia to where you have to be placed on a mechanical ventilator, right? They'll put in the artificial airway, they have to ventilate you. All right, so that's what's happening in the OR. A lot of people don't know that, and they have sore throats. It's because of the endotracheal tube, which lasts a couple days. about the McGill forceps, not be used in neonatal, we would never do that. So Mallampati score, this is what anesthesiologists do. When they're coming to assess their patients, right? Patients in the pre-op, they're coming to put in an IV, right? They're gonna tell you to open your mouth, and it's called the Mallampati score. So open your mouth. If you have no obstruction, if they can see that little punching bag, right? That's called the uvula, that little punching bag. And if they can see the back of the palate here, the hard palate, soft palate, then they know they're gonna have enough space to intubate you. It will not be a difficult intubation. So that would be the easiest intubation, class 1. As you start to lose the opening, it gets class 2, class 3, and if they try to if they opened your mouth and they can't see any space, then that tells them that that would be a really hard intubation. Maybe somebody with a short neck, okay, a lot of adipose tissue, that would be a class 4. So they have to know what they're getting into before they're gonna put you under anesthesia, maybe depress your respiratory drive to breathe, and then they find out in the OR, hey, I can't even intubate them. So they'll give you a score, and that's called the Mallampati score. All right, you see our sniffing position here? I'm gonna put them in sniffing position so that you can open up their airway a little bit easier. Okay, so for our procedure, here we go, we've already gone through it. So you've got the laryngoscope in your left hand, blade in your right hand, you put the patient in the sniffing position. You're gonna hyperoxygenate them, 15 liters per minute for your ambu bag, right? Just say 15. You're going to, when you put your blade in, you're gonna put it into the right and sweep the tongue to the left. And that's just to get the tongue out of the way so that you can intubate with the right, okay? You have about 30 seconds to do this. So if somebody else is intubating, you as a therapist, what do you think you're paying attention to? Because they're down there, they're looking. What are you watching?
Oxygen?
Right. How are you watching their oxygen level? What are you watching?
Oximeter?
Huh?
Is it called oximeter or the little?
The flow meter?
No.
You're watching the flow meter?
Isn't there like a display that shows your oxygen level?
Yeah, so you've got a monitor, and you're watching the oxygen saturation, right? You're watching the oxygen saturation. So let's say he's trying to intubate, and he's not checking time or how long he's in there, and your patient starts to desaturate, okay? So he's in there, and he's really trying, and you're going below 90%. What do you think you would do? Huh? I can't hear you, Joan. So you tell the physician, hey, we need to stop and we need to give them some oxygen. So you're gonna bag them, okay? You're gonna give them some oxygen, give them some breaths with 100% oxygen at 15 liters to get their stats back up, and then we'll try again. So he's counting on you to pay attention to the patient, all right? Okay, so we don't exceed 30 seconds. Where are we here? Okay, the first thing I've said, right? If you're asked that on a quiz, the first thing to assess tube position is chest rise. That is the first, and that's the easiest, that's the quickest. If you see this word quickest, that's the quickest, is chest rise. We're gonna also take 3 places, I told you. We're gonna use the CO2 detector, okay? If it's in the trachea, lots of times you'll see a mist when they breathe. You can see the mist in the endotracheal tube. That's another sign. Hey, it's my patient. It's in the correct place. All right. So we're going to manually ventilate, oxygenate the patient, and we're going to get a chest X-ray. Okay. That's what it looks like. There's your vallecula, the base of the tongue. Okay. This is called this physician gives sedation, all right? When they give sedation and we give a neuromuscular paralytic at times, when they do that, we're gonna, whoever's intubating, could be the anesthesiologist, will ask the therapist to give a little cricoid pressure, okay? Cricoid pressure is gonna be pushing in, right? In and up, right, on the trachea. In and up. So just gently, not really hard, just gently pushing in and up. And they'll kind of tell you exactly where they need you to push to use the pressure. So it kind of pushes the trachea more posteriorly so that they can see when they're trying to intubate. It prevents the patient from aspirating, okay? So on your boards, if they ask you to do that, they're gonna use this term, Selleck maneuver. Do you see that? If you see the term Selleck maneuver on your boards, which you will, 100% you'll see that term. I don't want you to be like, I don't remember, what the hell is that? That's what it is. You're just placing pressure on the trachea to assist with intubation. It's called a Selleck maneuver. Okay? We don't do it a lot anymore unless they're paralyzing the patient with a neuromuscular blocker, because sometimes they would press too hard and then you weren't getting enough oxygen to the patient. So they don't practice that as much anymore. Okay? Anything here that we didn't talk about? Oh yeah, so we didn't talk about this. So sometimes when you're putting a CO2 detector in it, what's the color when you take it out of the package?
Purple.
Purple. And when you have positive CO2, it turns to
Yellow.
yellow. So CO2 detectors can give a false negative in the case of cardiac arrest. Okay? Reason being, if there's no perfusion, right? If there's no perfusion because the heart stopped, there's no perfusion and you've intubated the patient and they're doing CPR, but there's not enough perfusion for CO2 to be exhaled out, that's not going to measure CO2. But you could still be intubated in the trachea. So it's not accurate when your patient is in cardiac arrest. So remember that. Because it might not turn color and you'll say, oh, it's in the esophagus, it's not in the trachea. But that could be a false negative. Does that make sense? Okay, what is the best way to determine tube placement? Best way. You guys gonna get that right on an exam? What's the easiest way? Quickest?
Chest
Chest
rise,
rise. Best?
X-ray.
Quickest is chest rise. Best is chest x-ray. Okay, don't get that wrong. All right, we talked about the advantages, disadvantages, poor mouth care if you have an oral intubation. It's easy, if you're orally intubated, it's easy for the patient to tongue out a tube or to bite a tube, right? They can gnaw on the tube. If they're gnawing on a tube, what do you think we would put in their airway so they stop gnawing on that tube? On a hard oral airway. You learned about that in 1531. Do you remember those? A hard plastic oral airway you put in, right, so that they're not biting down on their ET tube. I had one patient once that kept gnawing through the tube. She bit the tube in half. Bit it in half. So we had to extubate her and re-intubate her. Okay, rapid sequence intubation, RSI is how you're gonna see this. The difference between this and normal intubation is that with RSI, we are not bag mask ventilating these patients, okay? When you bag mask, if you get positive pressure with a mask, what is a risk to somebody that came into the ED, they're unresponsive, they were at church? Always happens, Sunday around 11 o'clock. We always come to the code room. Damn, they're at church. Right, they're getting all excited when they faint. Okay, so maybe they had a cardiac event. All right, I don't know what they had for breakfast. Okay, so if I'm bagging this patient, what can I do to the belly? Could I get some air? Gastric insufflation, we call it. So I can push some air into the belly, gastric insufflation, whoop, they vomit. Now, it's that they've aspirated into their lungs, now you have a whole nother problem. Okay? So, the RSI is really used in the ED when they don't know if a patient has eaten or not. Okay? So definitely reduces the chance for aspiration. All right, so you don't have to memorize these. It's just 5 Ps. We're going to prepare, get everything ready. We're going to hyperoxygenate them. Paralysis and induction. So we're going to give them sedation, these patients, and we're going to paralyze them. We give them a neuromuscular blocker, which is going to stop them from breathing. So we have to make sure everything's ready to go. All right? So, 2 things you do have to know about. All right? 2 things. What is that guy doing with his hand right there, pushing down on the trachea? What is that called? The Selleck maneuver. Okay? He's pressing down on the trachea, Selleck maneuver. So, 2 different ways you can do this. We can give, so this is prior to intubating, we can give a non-rebreather for 3 minutes. So if I ask you to do rapid sequence intubation, you can either pick a non-rebreather for 3 minutes or a nasal cannula at 15 liters for 5 minutes. Okay? Normally we don't go above what? On a nasal cannula. How many liters do we go to on a regular normal nasal cannula? You guys have to review before you start clinicals. They're going to ask you all this oxygen stuff, your instructors, and you need to know it. Nasal cannula. Can I go to 1 liter? Can I go to 2 liters? 3, 4, 5, 6. Can I go to 7? No, it's 6 liters, remember? 24, 30, 24, 28, 32, 36, 40, 44. It's like you have 44%. You guys have to review that before you go back to clinical. All right, they're going to ask you, and you're going to say, you need to know that. Okay, so here they're giving 15 liters for nasal cannula for 5 minutes. So you can pick one or the other. They're hyperoxygenating this patient, basically, is what they're doing. Okay? Hopefully they're breathing on their own, right? Because they haven't given them any sedation or neuromuscular blockers yet. So you're setting up on a non-rebreather for 3 minutes, let's say. Okay, then the doctor's they're gonna give the IV. They're gonna give IV opioids. What's opioids for? Opioids? Is it sedation or for pain medic management? Opioids? People over OD every day on opioids. They're pain, it's for pain, okay? So the doc's gonna give opioids, which is for pain. They're gonna give a hypnotic drug, which is called etomidate. That's their sedation. So they're giving, write down, pain med, sedation, okay? So they're giving pain medicine, sedation, which is etomidate, and they're gonna give a neuromuscular paralytic. Neuromuscular paralytic. So we can either give succinylcholine or rocuronium. One of the videos I heard the guy saying rocuronium. It's called rocuronium. Okay? And in the clinical setting, we just say rock. The doc will say, will you get me some rock? Okay? Rocuronium is a neuromuscular blocker. Write that down. Neuromuscular blocker. So it blocks the impulse from the nerve to the muscles so the muscles will not move in the entire body. Skeletal muscles are not going to move. It affects skeletal muscle. Okay? And we use rocuronium more because it's longer lasting and it doesn't cause hyperkalemia, increased potassium level. Yes? intubation is etomidate. So that's just to make the patient feel sleepy, okay? So they don't remember all of this nonsense. So 3 things when we're giving RSI, rapid sequence intubation. We're giving them pain meds, we're giving them sedation, and a neuromuscular blocker, which is rocuronium. Okay? We put the patient in the sniffing position. We do the Selleck maneuver or cricoid pressure. Okay, then the doctor is going to visualize the glottis, put the tube in, and then we can verify with, what's BMV stand for? BMV. It's an ambu bag. What do you think it stands for? Because that's how you'll see it on your boards, BMV. Bag, mask, valve. Okay? That's ambu bag. So BMV can be done. You can manually ventilate your patient now. Okay? All right. Is it time for a break? You didn't stop me, Mateo. I could keep on going. Was it 9:30?
Yeah.
Okay, so how many slides do we have left? 'Cause